So without further ado, I'm going to introduce Dr. Roxana Hemmati, who is a specialty contact lens fellowship trained optometrist practicing out of Austin, Texas. She graduated from the University of Texas at Austin with a Bachelor of Science in Nutrition, and then went on to receive her doctorate of optometry for the University of Houston College of Optometry. Dr. Hemmati continued her training by completing a postdoctoral fellowship in cornea and contact lenses with the Texas Eye Research and Technology Center, where she gained experience fitting specialty contact lenses and participated in a variety of clinical research projects. After completing her fellowship, she stayed on as a faculty at the University of Houston, involved in both clinical education and research related to contact lenses. Her primary research project was an NIH-funded study on wavefront-guided scleral lenses. Dr. Hemmati went on to complete the Boston Foundation for Sight Pros clinical fellowship and joined the faculty at Baylor College of Medicine, where she continued her involvement in clinical research and clinical care, managing complex corneal cases with many specialty contact lens modalities, including PROS and iPrint Pro. Dr. Hemmati has since relocated to Austin, Texas, and continues to practice with a primary focus on specialty lenses. She's a fellow of the Scleral Lens Education Society and the American Academy of Optometry. Thank you so much for being with us, Dr. Hemmati. Ashley Tucker graduated from the University of Florida with a Bachelor of Science degree in microbiology and cell science in 2006 before going on to graduate from the University of Houston College of Optometry in 2010. Dr. Tucker completed a cornea and contact lens residency at the University of Houston, where she received extensive training and experience in the diagnosis and treatment of corneal diseases and in complex contact lens fits, including patients with keratoconus, corneal transplants, and irregular corneas due to disease or refractive surgery. In addition, she has earned her fellowship from the Scleral Lens Education Society and currently serves as the Community Outreach Chair. She is a fellow of the American Academy of Optometry and diplomat of the American Board of Optometry. Dr. Tucker is a partner at Bel Air Family Eye Care and private practice in Houston, Texas area. She is also a visiting assistant professor at the University of Houston College of Optometry, where she is course masters for the Ophthalmic Optics Laboratory. Through her affiliation with University of Houston, she regularly provides continuing education on the topics of anterior segment disease, specialty contact lenses, myopia management, and ophthalmic optics. Dr. Tucker, it's a pleasure and honor to have you.
Thank you for joining us, everyone, and thank you for having us. Today, Ashley and myself will be talking about scleral lens hurdles, how to get from the fit to the finish line. Oh, there we go. So these are our disclosures. We won't have any bias about any sort of products during this presentation. And, you know, Ashley and I have both been fitting scleral lenses for a very long time. And whenever one of our colleagues about what to do, sometimes it can feel overwhelming, kind of like running hurdles in the Olympics. It's almost like one challenge after another.
We're really going to start from the front of the lens centrally, and then we're going to go out and talk about all the different things that can happen with scleral lenses along the way. So poor wetability, that's something that we see all the time, and unfortunately it can be due to a whole host of things. So we'll go through each one of these things. So untreated ocular surface disease, external factors such as makeup, face creams, hand soaps. It really can be attributed also to the cleaning regimen and then also the material that has been chosen for the patient. So untreated ocular surface disease, we're all familiar with dry eye disease, meibomian gland dysfunction. Bottom line is that these things need to be treated prior to putting a patient into scleral lenses. Otherwise, you'll be constantly chasing your tail. So you'll constantly be chasing your tail, trying to fix these things and then also fit at the exact same time. So patients that have a reduced tear breakup time, we all know that that means the quality of their tears isn't quite up to par. So we will need to address their meibomian gland dysfunction prior to fitting them in scleral lenses. Some of the things that we can do are warm compresses with massage versus in-office treatments. We all know the advantages of fish oil with DHA and EPA. Evening primrose oil can be helpful. Blackcurrant seed and GLA. Low-dose doxycycline, an antibiotic, can be very helpful in managing meibomian gland dysfunction. We also need to look at any underlying systemic conditions that can be associated with patients' dry eye disease. And then just looking at a toolbox of treatments like artificial tears, medicated eye drops, autologous serum, that can always be helpful. So there's a whole host of information here, but the underlying factor is that we need to treat the patient's ocular surface disease prior to putting them into scleral lenses.
So I'm back. I'm not sure my internet decided to to kind of
there
go out
we
first.
So that's okay. I took your first slide, so you can go for it.
Perfect. Yeah. So, you know, ocular surface disease is probably one of the most frustrating ones. And actually kind of talk about some of the you can use to manage it. But one thing I also tell patients, if we go back really quick, is that, you know, if they have dryness, even though we fit scleral lenses to help with dry eye, it's not treating the dryness, it's just managing it. So I don't know if you went over the photos actually, but you can see here that this had a lot of complement SBK, and in the long run, that was going to be a lot of big issues. And the middle picture is actually the lens on their eye for about 40 minutes. So it does still help. I mean, even after a short period of time, we're seeing a huge improvement in that surface. And then, you know, but the picture at the bottom is as the patient was wearing the lens for several hours. So all that front surface filming and dryness, the same thing that was happening on the cornea was happening on the surface of the lens. So as much as this is, you know, helping to manage the overall dryness, it's not treating the underlying condition. All the tips Ashley talked about are great to help with that. And I also just kind of inform patients that this might still be a factor even when they are wearing these lenses. And then if we want to go to that next slide. Another big culprit with surface non-wetting is just different external factors. So a lot of women like to wear makeup, and certain makeup, specifically oil-based makeup and then very shimmery, powdery makeups, those can get in the eye and stick to the surface of that lens. So I advise my patients to avoid those products if they can. Definitely put the lens on before they put on any makeup or eye creams, and really just avoid getting anything super close or near to the eyes. Another big culprit that people don't think about is your hand soap. Those moisturizing, fancy hand soaps feel great and they smell great, but they have a lot of oils, and those oils tend to stick to your fingers and then stick to the lens, and you can get a lot of surface dryness from that. And certain activities. So I do talk to my patients about activities that they like to do. I advise them to pay attention to those when they're wearing their lenses. I had a patient that loved hot yoga, and she noticed that that was causing her lenses to film up. So you don't have to stop doing those things, but just being aware that that can be a factor, and take your lens off before, or have a game plan for after the yoga class is a good tip for those patients.
Perfect. So that segues perfectly into cleaning regimen. So patients that wear makeup, you know, I'm wearing glittery eyeshadow right now. That's going to be difficult, you know, for some patients that really like to wear those products. So a lot of the cleaning solutions now, they kind of advertise no rub necessary, but I always tell my patients, don't skip the physical rubbing step. That can be really crucial in maintaining the surface integrity of these lenses and making sure that the front surface is wettable. But with that being said, we also have to be very careful in what products we are recommending, because some of the RGP cleaners have silica gel in that, and when the patient goes to rub, that silica gel can be very abrasive. Even though we may not feel it or see it, it can scratch the lens and basically ruin the lens front surface. I tend to recommend a lot of the time a hydrogen peroxide based solution, excuse me. I describe it as kind of the no-touch car wash kind of analogy to my patients, but sometimes it's necessary to have that rubbing step as well. So patients that typically use the hydrogen peroxide solution, I'll recommend 1 or 2 times a week, especially for women, to do the rubbing step just to make sure that the front surface is nice and clean. One thing to mention about this hydrogen peroxide cleaning case is that if we have a lens with a larger diameter, 16.5 or larger, we may have to recommend the Pros disinfection case. This is designed for the larger diameter scleral lenses. This can be purchased on dryeyeshop.com. And one thing to recommend here is that the patient should still have the clear care solution and the clear care case, but just break off that little silver activator and put it into this case. Patients are kind of wowed by that. They think that, you know, that wouldn't work, but that little activator it comes off pretty easily, and it just needs to be replaced every 30 days or so. And another thing to recommend is the protein removers, those enzymatic cleaners that Boston typically makes. These are utilized once a week. That tends to dissolve all the proteins that are on the front surface of the lens, and they can be actually put into a couple drops into the case with any of the conditioning solutions or the multi-purpose solution. Weekly tends to do the trick here. This slide is just a review of all the different materials. So material choice can absolutely affect wetability. So what tends to be the trend here is that the higher the decay, so the higher the oxygen permeability, the lower or the higher the wetting angle. So the higher the decay, we typically find that the lens typically wets less. So it can be really tricky to find a balance between a lens that wets well and a lens that gives you proper oxygen permeability. So it's just a personal choice. You just have to figure out what decay value works best for what you're trying to accomplish. A lens that wets well and also gives the proper oxygen permeability. So some additional recommendations that can help with wetability is plasma treatment and hydropegs. These are things that have to be added on to a scleral lens when you're purchasing them from the lab, or in my case, I just tell the labs that I work with that I want certain things on every single lens, so you don't have to specify every single time that you order. So plasma treating and hydropeg are two different things. So plasma treatment is an intense cleaning treatment that enables better interaction with water in the tears. So it basically makes the front surface of the lens more hydrophilic, and it tends to repel bacteria, protein, and other contaminants. The only thing with plasma treatment is that it tends to wear off over time. So as the patient especially manually cleans the lens, the plasma treatment tends to wear off over time. So we do need to keep that in mind. Some labs can re-plasma treat lens and other labs can't. So that's definitely something that you want to consider. Hydropeg is a surface treatment. It is not a cleaning treatment. It is something that is actually encapsulating the lens. This both reduces surface friction and decreases wetting angle. So it makes the lens more wettable. It makes the lens a lot more comfortable, and it tends to prevent any sort of debris or protein from depositing on the lens. And it also can potentially reduce fogging.
So the next hurdle we're going to talk about is air bubbles. Let me see if I can get that next slide. But air bubbles are not uncommon. They happen. For me, I tell patients, I always have my patients assess for an air bubble once they've applied their lens. And if they can see it, I have them take it off. Even if it's a small one, we don't know exactly how small is too small. Air bubbles, it's an air pocket. It's going to cause the eyes to get drier, and over time it can lead to a Dellen. And really small ones that move might not be a big issue, but as I said, we don't know how small is too small or how big is too big. So I like to avoid any issues with that. And if they see the bubble, I have them take it off. If they leave the bubble there, as I mentioned, it could lead to issues down the line. Larger ones, the patient will call you and say their eye is red and painful and watery, and 9 out of 10 times they've got a big bubble in there that they just didn't.
Exactly. Roxana, how do you tell patients to look for bubbles? I always am challenged with that question, and I don't really know what to tell them other than just get really close to the mirror and with the light source. Do you have any better advice?
So I do the mirror and the light. That's the first tip. I also tell them to, find either a picture of something or something in their bathroom, wherever they're putting on the lens, and look at that. The vision's a little bit blurry or distorted. That can also be a bubble. And I have them look at a light, like a ceiling lamp or a ceiling light, because if the light's scattering or they have a lot of distortions with it, that can also be a bubble. And one good tool, I actually don't have a picture of it here, but there's something called an eye check. It's a very magnified mirror with a little light that you can turn on, and you hold it very close. It just really magnifies the eye, and you could really see a bubble if that happens. But those are kind of little tips to do. And if they do have an air bubble, it's usually due to two causes if they're getting it continually. One is application, and two is the fit. So for application, there's a couple of things I remind my patients is always overfill the lens. These are large lenses, and it's better to have it overfilled and kind of bubbled over, and you're gonna be less likely to get a bubble with that. If you have a little bit of gap in there, air can get trapped when you put the lens on, and you can get a bubble that way. The other thing to do is to make sure you go all the way on. So patients feel that liquid and they think the lens is there and they start to retract the plunger, but it's not all the way on. And so I usually tell my patients, when you feel that liquid, keep going. And even when you think you're there, just go a little bit further. That way you'll really be sure that that lens is all the way on. And another good little tip to do is to let go of the lids before you pull back the plunger. The lids will kind of help to capture that lens, making sure it doesn't pop off again before you pull that plunger away. And I think if we go, let me see if that next slide will pull up. Another big tip is keeping their head parallel to the ground. If their head is a little bit tilted back or sideways or something, they can also tend to knock out some of that liquid, which will lead to the bubble. And if they're doing everything great with application and all that's doing good, it could be your fit. So the next video is actually a patient of mine that on the eye, the lens actually didn't look too bad, but every time they blink, you're gonna see that lens lifts up and gets caught on that lower lid and a bubble shows up. So it was very strange to me how that bubble was getting there, because on the eye, the lens looked okay, but you know, sometimes you have to adjust the fit, which kind of leads us to our next big hurdle, which is scleral lens landing challenges. So, you know, I feel like landing, Ashley probably feel the same way. It's probably one of the biggest hurdles and most overwhelming, kind of like this slide. We hear all these terms and things to do with steepening and adjusting and flattening. But if you really break it down, you go to the next one. When you have tight haptics, there's a few options of what it can be. If you have looser haptics, there's really two options of what it can be. And beyond those, there's a couple different extra steps we can take beyond just adjusting the haptics to get a better fit. Toric and quadrant specific haptics, which we're going to talk about as we move forward, impression-based designs, and using this Corneal scleral topographer guided design. So like I said, it can be overwhelming, but as we go through it, you're going to see that each thing is pretty simple once you break it down.
Yes, so thank you so much, Roxana. I totally agree. This is, for me, when I was first starting, the most challenging, but I started fitting when there weren't toric haptics. So lenses have come a long way. So this is the best time to be fitting sclerals. Things make sense. We can make these linear changes that create lenses that just fit the patient well, and it can actually make sense when you sit back and think about it. So the first thing we're going to talk about is conjunctival vessel impingement versus blanching. So this is really two manifestations of basically the same problem. So when you have impingement, which you see in the top picture, versus blanching, which you see in the bottom picture, both of these things are caused by local pressure on the conjunctiva. So essentially the lens is too steep. In the top picture, the very edge of the lens is too steep. So we're getting impingement of those vessels along the peripheral edge of the lens. And then the bottom, where we see the blanching, we have a more widespread issue, where we're seeing blanching more proximal into the lens. So we can get this localized pressure from a few different things. So presence of a pinguecula or a peripheral obstruction, that one's pretty obvious. If we have a pinguecula of some sort, nasal or temporal, we can expect compression there because it's an obstruction. It's not naturally there. We'll talk a little bit about how to fix that a little later. You can also have an irregular scleral shape that we'll call sectoral blanching or impingement. We know that most scleras are not symmetric, so we're expecting to see some sectoral impingement or blanching on most of our patients if we're not fitting toric haptics. And then lastly, we can have a poor fitting landing zone 360 degrees. So we just have a lens that's poorly fitting everywhere in the landing zone, and we'll have to adjust appropriately. The issue with this is that if it's left long-term, it can absolutely cause staining once we remove the lens, and then it can eventually cause conjunctival hypertrophy, which we do not want. That is something that may be semi-permanent for the patient and may cause a bigger issue than just this redness that we're seeing here. So the picture on the right is vessel impingement, and the picture on the left is just a reminder of what blanching looks like. I do want to note here that vessel impingement is not always a bad thing. If it's localized, if it's not causing any staining, if it's not causing any physical pain to the patient, a little bit of impingement is okay. I don't want you to leave here thinking that every aspect of the lens has to be perfect, because sometimes that's not impossible, especially when we're using diagnostic fitting sets to do these sorts of fits. So if it's causing redness, if it's causing irritation, if it's causing just bigger issues, then it does need to be addressed, absolutely. Now, if you have an eye that looks like this, you have this area of blanching that also has this localized hyperemia, of course, we will need to address the landing zone or create some sort of toric haptic for this patient. So conjunctival hypertrophy, I kind of alluded to this. This is kind of the long-term effect of letting the lens fit poorly in the periphery. So this is due to long-term lens compression. Either blanching or impingement can cause this. This is one of Dr. Hemmati's patients. You can see initially I thought maybe the lens was still on when I initially looked at this picture, but I realized that the lens isn't there. There's compression there, and then there's this area off to the side here where this black arrow is that you can tell where the lens would be, and the tissue would be kind of heaping over the edge of the lens. So this is unacceptable. This is a side effect of long-term compression that would need to be addressed. So what we can do here is we can adjust the haptics in that specific area. More than likely, we would need a toric haptic here. We could also go larger. We can increase the overall diameter just to kind of go over that area of irregularity after this is healed, of course. And then sometimes there's really nothing we can do. You can try all of these sorts of things, and we still have this area that's kind of prone to irritation, and you may have to discontinue the lens either short-term or long-term for this patient.
And so I have to give I was going to give a little disclaimer about that. I inherited this patient. He was actually fitted a long time ago, and the previous fitter had told him that you need to be refit, and he didn't come back. So it was not on the previous fitter.
I'm so sorry. I should not have implied that this was your doing.
I also say that because it is due to long term. So if you have a lens during the fitting process is a little tight, don't panic and think that, oh my gosh, I'm going to get this ridge after they've had the lens. They take the lens home. A week, even a couple months in a tight fitting lens during a fitting process is okay as you're making those adjustments. But this was years of the patient wearing a lens that we had told him was not good. And this was the result of that. So keep that in mind. This is really just long-term issues, but that's why you want to make those adjustments during your fitting so you don't get these problems down the line.
Absolutely, totally agree. So this is just a lovely picture of an OCT image, just looking at the lens periphery. So just to kind of orient you here, this black band here is the lens edge, and then we have the conjunctival sclera here, and then the cornea underneath the lens. So what we would expect to see, because we have this tissue heaping over the edge of the lens, we would absolutely expect to see vessel impingement here. This is exactly what vessel impingement will look like when you are looking at the OCT lens profile. So what the patient will report is discomfort after a few hours of wear, and then also rebound redness after lens removal. I tend to find that patients, they will report discomfort, but sometimes it doesn't happen until a few days into wearing the lens, but absolutely the rebound redness after the lens removal. Patients will also say that when the lens is especially tight, that they're able to wear it one day, but the next day their eye gets really sore and they're not really able to comfortably wear the lens. The patient may also tell you that they have a compression ring after lens removal. Most of us that have been fitting know that a little bit of a compression ring that lasts for, few minutes to an hour after lens wear may not necessarily be a bad thing, but a compression ring that is really obvious, that has that rebound redness, would warrant taking a look at the lens periphery. I mentioned that we'll talk a little bit more about notching or microvaulting for those peripheral obstructions like pinguiculas. I think Dr. Hemmati has a case here coming up soon. You really want to consider toric diagnostic lenses. I exclusively fit toric diagnostics, I exclusively use toric diagnostic lenses now. Like I said earlier, years ago when I first started fitting, that wasn't an option. So I'm so infatuated with having that option that I just tend to fit it on everyone. There are times where I make changes and I realize, oh my goodness, I'm back to a standard periphery, and that does happen. But more often than not, the toric diagnostic lenses are kind of avoiding these issues, or at least minimizing them when compared to fitting years ago. Corneal scleral topography is a wonderful addition to our arsenal for fitting scleral contact lenses. They can help you create toric or quadrant specific landing zones that are even better than just trying to do it with a diagnostic set. And another thing that you definitely want to consider are the impression-based lens designs that can really, really hone in on all the imperfections of the patient's conjunctiva and sclera that can really help you get a lens that fits the patient like a glove. So that one tends to be higher in price, so it's something to consider, but it needs to be an option, especially in your arsenal for your patients.
Yeah, and even with those ones, kind of knowing what you need to adjust and how you want to approach it is still super important. And then going back to what Dr. Tucker said, you know, fit sets used to be all spherical. We now know that there are our scleral anatomy is more toric. More and more fit sets are coming out with toric haptics. So, you know, that makes the fitting process a little bit faster. But even if you don't have that, if you start with the spherical haptic, what I usually recommend is make your big changes overall. If it's a very loose lens or very tight lens, either steepen or flatten the lens 360. Once it starts to do a little bit better in one area, then you can kind of see if you need to adjust the other meridian. Just like this patient here, you can see that it's still very tight nasal and temporal, versus it fits pretty well superior and inferior. And by doing a toric haptic and flattening the nasal and temporal meridian, they did a lot better 360. Same quadrant specific, you know, first adjust your 2 meridians, get, you know, at least 3 of the meridians good. And if there's still 1 meridian that's off, then you can make that quadrant specific change if your lab has that. And then, you know, if you are trying to look at a quadrant specific change, sometimes that means you have an elevation, as Dr. Tucker mentioned, like a pinguecula or a cyst or something like that. And instead of going to a quadrant specific option, which you can also look at is doing a microvault or a notch. So a microvault is just like the name sounds. It's a small vault that goes over that conjunctival elevation or abnormality, while a notch is actually cut out around that. So we go to that. I don't know if my clicking is working, but there we go.
Oh, yeah.
If we go with a microvault, they can be very intimidating at first. The first time I added a microvault to a lens, I just felt like I did not know exactly what I needed to do. But they're actually pretty straightforward. You just want to measure the length of the elevation, the width, or how far it goes in from the edge of the lens, and then how deep it is. And that's probably the trickiest part, is to figure out the exact depth that you need. And I've gone with one estimation that for every 1 millimeter in the size of that elevation, you want to go 100 microns in depth. So if it's 3 millimeters wide, go 300 microns in depth, and you can kind of make adjustments from there. With a notch, the nice thing is that you don't have to worry about measuring the depth because you're just cutting around it. So you really just need to know the length of the width. And in some cases, I've actually put the lens on and just taken a Sharpie and drawn where I need that notch. And I've been able to send that to the lab and have them cut that notch out. Definitely check with your lab first to see if that's an option that they will allow, but I worked with some that have allowed that for me. And just be mindful that you can only make the notch so big. If you go really big, the patient's going to be more uncomfortable. They're likely to get bubbles. So you do have to be mindful of that. But both these options work great for, like I said, various conjunctival elevations like pingueculas, cysts, things like that. The next slide, though, goes over an elevation that personally for me, I tend to only use an impression-based design, which is a bleb or a tube shunt. Those I don't like to avoid. I want to avoid anything from touching it. So even with microvaults, as you're making those adjustments, at times it can press in certain areas. And personally for me, I just don't like to risk that. So I go with an impression-based design. And a case like this one, you know, sometimes a notch can be an option for those patients, but this one was so close to the limbus that a notch, they were going to get a bubble, is going to be very uncomfortable. So for this specific case, we actually went with an impression-based design. So you can see on the next slide, we have the impression that we used. They did a 3D scan of it, and then they built the lens based on that 3D scan. And then in the next slide, you can see that it kind of fits perfectly over that elevation. So just like with a microvault, you won't see where that, you know, dip or change in the edge of the lens is. It sits very evenly and smoothly. Impression-based designs do the same thing with those sort of elevations.
All right, so now we're going to look at the opposite problem. So we were just looking at a lens that was too tight. So now let's look at lenses that could potentially be too loose. And what that typically manifests in is edge lift. So what the patient will describe to you is that they really can feel the lens. They will report an awareness or a discomfort, especially when they're blinking, because basically the edge of the lens is lifted up off of the conjunctival and the sclera. So the fact that they're feeling it always gives me pause and makes me think, okay, I need to be looking in that specific area where they're feeling, because more than likely the lens is lifting off of the conjunctiva there, or the sclera, I should say. So if we have too much edge lift, or if we have a significant area, or if we have like a whole meridian where there's edge lift, bubbles could form and potentially cause reduced visual acuity. That would be in an extreme case. But what we recommend here is steepening or tightening the peripheral curves. You may need to do a toric haptics, which we keep kind of beating into your heads, or maybe even a quadrant specific design. One thing that I like to do, just to kind of hone in on exactly the area where the edge lift is a problem, is I paint the lens, both the top and the bottom, with fluorescein, and then I quickly get behind the slit lamp and watch the patient blink. And that can be so useful. That can give you so much information, because you can watch the fluorescein seep into the area, whether it's in a specific meridian or if it's in a quadrant. You can tell exactly where the edge lift is happening, and then you can tell the lab or design it yourself that area where you need to steepen or tighten the lens. So we've talked a little bit about scleral topography. Here are a few examples of some topographers. We can't really mention names, so if you want more information, we can absolutely talk to you about that. But scleral topography is a wonderful addition to fitting. It can really help us figure out these edge profiles that are very specific to each patient, that can help the lens just align with the sclera, and not having any of those areas of either edge lift or a lens that's too tight. Is this your slide, Dr. Hemmati? I'm sorry.
Whichever. Well, yeah, no, this is just a perfect example of edge lift, and where we use those advanced technologies to help with it. So this patient was, this was her first lens. She was having a lot of edge lift. I totally agree with Dr. Tucker too. That fluorescein trick is the best. There's times where it's hard to assess that shadow and see if it's lifting or not, and the fluorescein is a great way to check. But if you have access to a corneal scleral topographer like we did with this patient, what we were able to do in the next slide is we were actually able to measure how she actually had. So you can see she has a pretty toric sclera. It's pretty different from the nasal and temporal side. And we actually used this information to design her lens, and she did a ton better. So this is an example of how these different technologies are helping us further advance and further improve our lens fittings. And then,
so we spent a lot of time talking about bad landing zones. So we just wanted to put a picture of what a perfect landing zone looks like. So you can see here, there's no vessel impingement, there's no blanching, there's no shadow, which would indicate that there's edge lift. So this is what we're looking for. We just want the lens to align with the sclera and just basically be one with the eye and not cause any redness or any issues here. And this is an ideal landing zone seen on the OCT. So again, that lens edge is aligning with the sclera and not having, there's no gap between the sclera and the contact lens, and then there's no conjunctival tissue heaping over the edge. So again, ideal landing zone here. Oh, sorry about that.
So the next part we're looking at is midday fogging or tear reservoir debris. So we talked about the front surface dryness, that's all on the outside. This is all underneath. And this is another fun one that's, and I say fun a little jokingly, it's not really fun to deal with in office. And in case you don't know what it looks like, because I've had some people kind of not be sure, let me skip this video ahead just a bit. This is a patient that had a lot of midday fogging that was due to the lens actually being too loose, which Dr. Tucker is going to talk about a little bit more. But you can see there's a ton of debris and little particles behind their lens that after wearing the lens for a few hours, their vision was degraded and they weren't seeing as clearly as they were when they first put it on.
So there's two different theories for tear reservoir debris and fogging. We honestly do not know exactly what causes it. We do know it is probably, I don't know if Dr. Hemmati agrees with me, but one of the most challenging and trickiest things to deal with patients, because you really can feel like you have a pretty ideal fit, and the patient will come in and say, yeah, everything's great, except when my lens fogs up after 3 or 4 hours of wear. And that's like a punch in the gut. So two theories. The first one is that there's potentially a poor edge design or inadequate landing or lens edge alignment. So basically the lens is a little bit too flat somewhere along the way. And what this allows for is uptake of debris from the tear film to get into the post-lens fluid reservoir, but that debris cannot get out. So it's essentially trapped in there. And I really think that's what was happening in Dr. Hemmati's case that she just showed. And now theory number two, which is very different, but still a possibility, is that we know that corneal epithelial cells turn over relatively rapidly throughout the day. And when a scleral lens is in place, those cells are released from the ocular surface and they become entrapped behind the lens. This can be more of a problem when a patient is using a solution that may not be compatible with their ocular surface. So here are the recommendations. There's a ton of them. The first thing that I always look at is that edge, the peripheral landing zone. I need to make sure that there's no potential for debris to just flood into my lens. So I always do that fluorescein trick with painting the lenses just to see if there's anything I can do about my fit. I always take responsibility first. If there's something that I can do. This is extremely common, especially in patients with atopic disease, ocular surface disease, and then those post-surgical eyes. They just tend to be more prone to this, but this honestly can happen to anyone. Another thing to do is to look at the solution that the patient's using. This could be an easy fix. The patient may be filling the lens with Biotrue or some other sort of multi-purpose solution, which we know would not be compatible with their ocular surface. So look at that. Other times patients are using the preservative-free salines that we recommend, and we have to get creative and use other types of products, maybe a neutrophil or a preservative-free artificial tear. One thing you absolutely want to avoid is a viscous GP solution, because that essentially acts like glue to the front surface and the inside surface. So that's really going to cause debris collection on the lens. But contrary to that, you may need to use a more viscous filling solution like a Celluvisc or a preservative-free gel, just to kind of keep that flood or influx of debris from coming into the lens. Of course, treat any ocular surface disease like GPC, meibomian gland dysfunction, and dry eye disease. Those tend to kind of enhance or exacerbate these issues. If the debris and the fogging is bad enough, it'll affect the patient's visual acuity. And sometimes patients, no matter what we do, we've changed the fit, we've changed their filling solution, we've done everything that we could potentially do. Sometimes they just have to take the lens off midday, clean it up, and refill it. I hate to resort to that, but sometimes it's just inevitable. Dr. Hemmati, this is a big topic. Do you have anything to add here?
No, I feel the same way. It's always a balance of, you don't want the lens to be too tight, but you don't want it to be too loose for getting this excessive fogging. When I do the fluorescein test, I want to make sure it's not rapidly going in, but I do want to make sure that if I try to push that fluorescein using their lid, it'll go under. And I'll tell patients that if you wear the lens long enough, you're going to get fogging. So if they wear their lens for 12 hours or 16 hours, they might get some fogging at some point. And that's
I'm okay with that.
Happening with a couple hours, and I'm like, that's not ideal. But after like a whole year, if they have some clouding at the end of the day, it's okay, because going tighter on that is going to cause other issues. So it's an inconvenience for the patient. It's annoying, but you know, it's okay if it happens at the very end of the day. So just and they can just take the lens off and put it back on, and they can keep going with it. And so the next few topics are, little things that you might run into that you don't really think about ahead of time. One is lens decentration. And to be honest, this isn't really a big hurdle because it's not that big of a deal. Lenses tend to decenter. Gravity and eye anatomy tends to pull that lens down inferior nasal. And when I have a lens, a little bit decentered, I look for a couple things to see if it's okay. One is the limbal clearance. So I want to make sure that superiorly it's not sitting too close as it's shifting down. And I want to make sure at the very bottom, I don't have too much limb where I'm getting neovascularization or conjunctival prolapse, which we're going to talk about later. But as long as that's doing okay, it's not too big of a deal. The other issue you can run into is if it's decentered a lot and they have a larger pupil, they can start to hit the edge of that optic zone, especially at night when they're more dilated. And that can lead to higher order aberrations and just decreased vision. So if your patient's complaining of that, make sure your lens is more set. And in order to do that, the thing we've talked about a million times, toric haptics, quadrant-specific haptics will definitely help with that centration. You can also alter the diameter, go a little bit smaller. That'll kind of reduce the weight of that lens to shift up a little bit more, and bringing down that central vault. You don't want to go too close that you're touching, but if you have too much central vault, that will also cause the lens to move down a little bit more.
All right, so we're kind of getting into things that are less common, but we still wanted to pull them in. So hypoxia and edema, we always have to think about the potential of edema. I mean, we're basically putting a lens on that may be affecting the integrity of the cornea. So some key considerations. Oh, my slides keep popping over. So scleral lenses, we do know this, induce chronic corneal edema when the lens thickness is greater than 250 microns. So we want to be cognizant of the thickness that we were ordering for our lenses. Most of them are within a normal range. And when clearance exceeds greater than 200 microns, so you may be thinking, oh my goodness, that's typically what I aim for. And that's okay, but we just have to be mindful that we could be inducing edema if we are exceeding these numbers. So we do not want to fix sclerals if the endothelial cell count is less than 800 cells per millimeter squared. We can get that value from doing specular microscopy. I know we don't routinely have that, but a lot of us are getting referrals from corneal specialists, and that's something we absolutely need to be requesting and just getting a heads up on what that value is. And we want to fit with caution if the endothelial cell count is less than 1,000 cells per millimeter squared. So we want to keep a close eye on corneal transparency, especially in those post-graft patients, patients that have endothelial dystrophies like Fuchs dystrophy. Any patient that has any sort of compromised corneal integrity, we want to be watching for this. Factors to consider is we want to use a high decay material with as thin of a center thickness as possible. You definitely want to consider frequent lens replacement. I know a lot of our patients want to keep their sclerals for as long as possible, but when you have a patient that potentially is at risk for edema, we want to make sure their lens is current. We want to make sure their lens is promoting corneal health and not compromising their eyes at all. So I tend to recommend for these patients replacing their lenses annually at the very minimum. And then we also want to carefully assess limbal clearance. We'll talk about that a little bit more in the next couple slides, but ideally we want 50 to 100 microns of limbal clearance. We want to protect those limbal stem cells and make sure that we're promoting good corneal health by not having a lens that's bearing on the limbal area.
And another hurdle is, bulbar redness. If you have a patient come in with a very red eye, once again, we kind of want to know what we're looking at and what we could potentially use to address it. One is obviously mechanical trauma. If that lens is too tight, or if it's touching the cornea or touching the limbus, your eye will get a little bit redder. If we're not getting enough oxygen to that eye, it could also cause it to become a little bit more injected. You can start to get some of those neovascular vessels along the limbus starting to fill up. Making sure they're using the right solutions. If they're having something that has preservatives in it, that can lead to toxicity. And then, as much as microbial keratitis is rare in GP patients, it can happen. And so you do want to assess for infection if your patient is complaining that their eyes are getting red, and making sure that everything looks nice and healthy with that cornea. And another hurdle is corneal staining. Now, this one isn't quite as common because your lens should be clearing over that cornea. But as Dr. Tucker mentioned, some cases you have to fit a little bit closer to make sure it's getting enough oxygen. If you have a cone that has a very steep apex, you might be landing a little bit closer to it. Whenever I have a patient like that, I always take the lens off, check for any staining to see if it is touching. Keep in mind these lenses do settle throughout the day, so later in the evening it will sit closer than whenever you see it during the day for your exam. So you do want to see if at any point you're seeing any irritation on the eye. And then you also want to check with their solutions. If you're seeing kind of a toxicity reaction, like in that top picture, you want to make sure their solutions are preservative-free that they're using. Any eye using, like, any artificial tears on the eye is preservative-free. They aren't using any medicated drops on their eye, and just make sure they're avoiding any preservatives from getting in there.
All right, so neovascularization. I don't know how you guys feel about this, but this is something that I am very, very, very watchful of. I never, ever want to design a lens or have a patient in a lens that would cause neovascularization or exacerbate the neo that they already have. This can be very serious, especially in post-transplant patients. I always tell my patients, I'm going to treat your graft as if it were mine, because we really do want to protect these grafts and make sure that we can preserve the longevity of these potential grafts. So we do not want to do anything that could shorten the lifetime of them. And if we allow a lens to create a neovascular net, like you're seeing in some of these pictures, it could cause the graft to reject. So this is something that I know we all take very seriously. This is almost exclusively secondary to a lens impinging on the limbal region. So that is seen in the picture in the bottom right. You see that area, it's almost 360 degrees of darkness in the limbal area. So that means that the lens is basically bearing there and cutting off oxygen to the cornea. So those vessels are growing to create an oxygen source, which is not a good thing. I would highly recommend, I think both of us would, photo documenting. A lot of your patients that are going to be referred to you are already going to have neo. So they already have that vascular process starting in their eye and their body. So it's very easy to exacerbate that. So recording by photo documenting, by writing in your chart as much as you can about where the neo is and where it is in relation to the graft is really important. And then if you're doing anything as far as your fit that's making this worse, you need to take a step back and readjust the fit for sure.
And that's, I agree with the photo documentation. I have a lot of patients that come in that already have a lot of neo, and the lens is actually helping them. But I also, the highway's there. When those ghost vessels are there, the pathway's there, it's very easy for them to fill up. And so I like to document where they're at, see where they're at the follow-ups. That way I can see if those vessels are starting to retract or if they're getting worse. If they ever get some eye irritation, it's not uncommon that those vessels will fill back up again.
Mm-hmm.
Documenting and watching it. That way you can know that you're not making anything worse along the way.
Absolutely. And this is just an actual image of ideal limbal clearance and then an OCT image of limbal clearance that's appropriate. So that 50 to 100 microns, that's about where we want to be. And that is a value that I'm really protective of. I'm really always striving for that 360 degrees, because otherwise you could potentially promote neo or make it start. So the ideal limbal zone, no, this is not the ideal limbal zone. This is bearing the limbal zone. So if you see the picture on the top left, we have a big area of clearance centrally, and then the fluorescein starts to get really thin out towards the limbus. And it may be looking like we're clearing here, and maybe we are at the very start of the day. But as the day goes on, the lens, we know that the clearance and the sagittal depth tends to decrease. So that lens starts to bear on the limbus and starts to cause the eye to get irritated. So when we pull the lens off, you can see we have some epithelial compromise right near the limbus. So that is truly impairing the limbal stem cells and from doing what they need to do to promote corneal health and corneal integrity. So reassessing this fit, basically just making a change at the limbus 360 degrees is going to make this lens fit so much better. All right, so do you want to add anything?
Oh no, I was going to say, you mentioned, taking the lens off, and I think that's such a big thing that we can't forget. Take the lens off, take a look, stay in the eye. Even if the fit looks great, you'd be surprised how many times you realize that it is touching in some area at some point, and it, so definitely.
I agree with that, because it's, in the big scheme of things, when you're busy and everything seems to look good with the naked eye or even with the slit lamp, these things can be cumulative. They may not start having issues until a few months in after the warranty is up, and then you'll be kicking yourself when you realize you could have done something during the warranty period just because you didn't take off the lens. So it is so important to take a step back and take the lens off. It only takes a few minutes and stay in the eye, so you can get a lot of great information there. I agree, Dr. Hemmati. So next we'll talk about conjunctival prolapse. So this is basically entrapment of the conjunctiva that's draping over the cornea near the limbal region underneath a scleral lens. So we have this loose conjunctival tissue that's being sucked underneath a particular area of the lens, and it's just being pressed on the cornea. This is very common in elderly patients. Most of the time, it's completely benign. It doesn't tend to bother me that much. I always take the lens off and just make sure that the tissue kind of goes back where it should. But sometimes you may need to alter the fit to improve the appearance because it can be very dramatic in certain patients. So some of the possible reasons for getting this conjunctival prolapse, another name for this is conjunctival hooding, is that the diameter of the scleral lens is a little bit too big. The lens could be decentering, and as it's decentering, it is dragging that conjunctival tissue with it. The lens could be fitted with too high of a clearance over the limbal area. That will definitely promote that prolapse. And then you're almost always going to get it when the patient has conjunctival cheilitis. That is very common again. It's just basically loose tissue that we see a lot of times in elderly patients, but you can also see in patients that have ocular surface disease or patients that have a history of surgery in their eyes.
Yeah, so especially if I see a patient that has conjunctival cheilitis to begin with, I kind of already prepare to see some prolapse. And as Dr. Tucker mentioned, it's not a huge deal, but when it does start to become an issue, this is the patient, you can see that prolapse, you can see it there, it's going pretty far up in their lens while they're wearing it. And then we kind of already said this now, you always got to take the lens off and look after. And with this case, when we took the lens and looked at the eye after, you can see that there's some haze still showing up in that bottom left corner, and there's some neo starting there. So that means that that tissue that's getting sucked under is either starting to stick to the cornea or is blocking oxygen from getting to the eye. Both two things that we don't want. One thing that was always taught to me was when you take the lens off, you want the eye to look like nothing had ever touched it to begin with. You never had a lens on the eye. And that doesn't always happen, but you want to at least try for that. And especially with the cornea, you really want to make sure it's not affecting it negatively. So a case like this, I actually referred this patient out for conjunctival cautery. So we'll talk about that in just a moment too. But when you do have a patient with prolapse, first thing you can do is just monitor. If everything's looking okay, just keep an eye on it. If it's a severe amount of prolapse, you might want to follow up with them, more frequently, like every 3 months or rather than once a year, just to see how their eye is doing. You can also adjust the diameter. Going a little bit smaller sometimes keeps the excess tissue from moving under the lens. We talked about adjusting the haptics, going with a toric haptic, quadrant specific, or just getting it a little bit better. And something a little bit tighter will help keep that prolapse from accumulating under the lens. And then reducing the vault or the limbal clearance. Just having too much vault and specifically too much limbal clearance kind of gives a space for that prolapse to kind of push under and get there. I don't like my limbal clearance to be too close, but especially when there's prolapse, I will bring it down to that 50 micron limit and try to keep as little of that prolapse from getting under there. Now, there's mixed opinions on this, but there are some surgical options that can help. One is conjunctival cautery or conjunctival excision. Cautery is when they're kind of, burn that tissue and it sort of shrinks a bit. Excisions when they actually excise some of that tissue. I worked with a surgeon who liked to do this a lot, and it does tend to help, especially with those really excessive cases. Now, this photo is just kind of a cool photo. This is a patient that had conjunctival excision that was just taking a longer amount of time to heal. So you typically don't see them in this stage. Once they've healed, it just looks like a perfectly smooth conjunctiva. This one just happened to take a longer time to heal. So when we delayed her fit, but I just thought it was cool. So we took a picture to see. So they really do just make an incision and kind of re-sew the eye together there. With this specific case and the surgeon I worked with, we definitely consulted to make sure we did the incision far enough out that it didn't affect it. And we tried to see how much tissue we actually had to take so it wouldn't interfere with the lens. Something else to keep in mind with this is that it's not uncommon with either cautery or excision that you might still get some prolapse underneath the lens afterwards. A little bit is still okay. It's going to happen just like before. You want to monitor it, but this is just getting rid of that excessive amount of prolapse.
Okay, so reduced vision. I tend to tell patients this is the least of my worries. For me, the vision part is the easy part. That's what we're all just naturally good at as optometrists, but we do need to address it. So some secondary reasons there are some reasons that can be the cause of reduced vision is an air bubble. We talked about that. Excessive tear reservoir or a uniform or ununiform fluid layer or thickness underneath the lens can absolutely cause reduced vision. When I'm teaching my interns and my students, I always tell them we don't want more fluid underneath the lens than necessary. I mean, it's just looking through unnecessary fluid. So it definitely is going to impair their vision if we have more sagittal depth or more clearance than we actually need for the lens. We want to stay within that 200 to 300 micron layer, tear thickness layer to promote good vision. Poor wetability of the anterior lens surface, absolutely, we talked about that. Scleral lens decentration, again, that's another reason, but we've addressed that. That just basically means the optic zone could potentially be decentered. If we have lens flexure or warpage, that can cause unnecessary astigmatism, or sometimes when the lens is warped, we'll get these over keratometry or over topography values that are not spherical when we know that they should be. So that just may mean that we need to replace the lens. Lenticular astigmatism, in an ideal world, we would want all of the patient's refractive cylinder or refractive astigmatism to be neutralized, but sometimes that doesn't happen, and that's likely due to lenticular astigmatism. So that leads into this next slide of adding front surface torics. So this is something that needs to be layered into your fitting process. You don't want to add too much at the very beginning. I tend to find whether or not I need a front surface toric during my over refraction, but I don't implement one until I have made sure that the fit is exactly what I want it to be, that the lens is perfectly stable. Once all of that has happened and I find a consistent spherocylinder over refraction after a couple visits, then that'll be the icing on the cake. That's the cherry on top. I always tell patients that I will add in that little bit of residual prescription that will sharpen everything up for them on the final step of the fitting process. We don't want to forget about our presbyopic options. I don't know about you guys, but I tend to get so excited when I've improved the patient's vision drastically from 20 whatever to 20/20 or 20/25. I'm so happy about their distance vision, and I feel like they should be happy too. But most of the patients that we're fitting are presbyopic, or a lot of them are, and they're ecstatic that you've improved their distance vision, but they want their vision to be improved also, and they have a right to that. So we have our two traditional options, our monovision and our multifocal. We have to be very careful on which option we choose for each patient. I mean, for monovision, we really need the distance vision to be pretty close to 20/20 in order to make that work at distance and near. And then kind of the same for multifocals. If we're going to put something onto the lens that could potentially impair their distance vision, we need to make sure their distance is as clear and consistent as possible. So just a couple quick things about the presbyopic multifocal options. We only have simultaneous vision options available to us. That makes sense. We can't have a translating design because scleral lenses do not move or don't translate like a corneal RGP would, and most of them are center near designs. The key here is setting realistic expectations. We do not want to tell patients this will be like their 20-year-old eyes or their pre-surgical eyes or their pre-disease eyes. We want them to know that we will likely be able to improve their up-close vision. Sometimes that means that we have to take some of their distance to get some near, but just setting realistic expectations are what is really important here.
And so another challenge and something else that's coming up more and more in the hot topic on scleral lenses is wavefront guided scleral lenses. So this is a good example of what higher order aberrations are for some patients. So looking at a point spread function here, which is what a little point should look like. The first image is what the point spread function would look like to a patient with keratoconus with no correction. So you can see it's extremely distorted and it's sort of all over the place. And traditional scleral lenses do help a lot with these higher order aberrations. The middle image is more of a traditional scleral lens, and you can see that it really does reduce the amount of aberrations significantly. But it is still there. It still doesn't look exactly like what our point spread function looks like. But then when we go to the wavefront guided option, that point spread function comes down a little bit more and looks even more like a point. Not quite the same as our initial one, but more of what we would expect with a typical normal eye. So for some cases, these wavefront guided scleral lenses are a big game changer and are giving a much better and much clearer. And I'm going to quickly go through this case. This is just a patient that we had when we were doing the study. He had keratoconus. One eye, his right eye wasn't too bad. His left eye, he was getting to about 20/40 vision. So I enrolled him in the study I was involved with at the VOI, the Visual Optics Institute at University of Houston. And so his eye uncorrected was around that top image. That's what the chart was looking like to him. With regular scleral lenses, the chart does improve. He's getting to 20/20 with the right eye, 20/40 with the left eye. And then with the wavefront guided lens, it improved even more. And then with the left eye, he actually even got down to 20/20 again. So that's a huge game changer. We're looking at these patients, considering, you know, sending them for a corneal transplant surgery if their vision's doing worse. Wavefront guided lenses can be a huge game changer. I know there's some companies that are starting to offer them with, you know, various different aberrometers to get those measurements and create those lenses. So definitely keep an eye out. It's, you know, the hot thing right now, and I think more and more companies are going to start to offer that.
All right, Dr. Hemmati. So we're finished with the actual fitting hurdles. So we just wanted to impress upon you guys that it all starts with passion. I know all of these different troubleshooting items can be overwhelming, and I'm hoping that we kind of simplify things for you. But if you are passionate about this, you can absolutely incorporate this into your practice and change lives. With that being said, educating yourself just like you're doing right now is key. And then putting everything together, prepare for it, and just go for it. Really, we are all more than capable of figuring out how to fit these lenses and be successful. Just a couple resources here: the Scleral Lens Education Society, which Dr. Hemmati and Dr. Kramer were all involved in. We are more than happy to be a resource to you guys, but these websites, both the Scleral Lens Education Society and GPLI websites, are full. They're full of a wealth of information, a wealth of resources, both for yourself and for your patients. So quickly, I know we're running out of time, so we'll quickly go through this. What if you feel like you don't have the proper equipment? You really don't need a lot. So I've broken this down into necessary equipment and nice but not necessary equipment. All you really need is a scleral lens fitting set. I would recommend a minimum of 2, but you have to start somewhere. So obviously 1 is a place to start. Slit lamp, you've got to have a slit lamp. We need that anyway. And then of course a phoropter or trial lenses to do the over refraction. Some things that are really nice are a corneal topographer. It's a beautiful thing to get an image of the patient's corneal profile, just so you have an idea if you need a prolate design or an oblate design, or if you really need to go to that impression-based design. That gives you a wealth of information. Along with that is the scleral profilometer. That is a fancy way to fit scleral lenses. Again, not necessary at all, but it is really nice when you're wanting to design a lens that fits very, very precisely to the cornea. And OCT gives you a lot of information. It actually allows you to quantify sagittal depths, clearance in different areas. It's a nice piece of equipment. Again, not necessary, but it can be really helpful in the troubleshooting phase of your fitting. And then anterior segment photography. That can be great for photo documenting scars, neovascularization. It could be awesome for photographing the fit, so that you can send that directly to the lab so they can give you some help. How do you choose which fitting set to obtain? Most major contact lens manufacturers have scleral lenses nowadays. I would really venture to guess all of them do. But all scleral lenses follow the same basic fitting principles. So it's not really difficult to just jump in there. But what you do need to do is choose the lab that you are the most comfortable working with, one that you already have a relationship with the consultants, or you at least feel comfortable with the way the consulting process goes with that particular company. Ask for their most successful scleral lens design and get it. You may want to get it in the large and the small diameter fitting set. That could be really helpful. And then keep in mind that not every patient is compatible with one particular scleral design. You may find that most of your patients are compatible with one particular one, but I would highly recommend having a backup.
And you can start with some fit sets and then, you know, add another one later if you need a different diameter. Specific patient companies will offer you a loaner set too, so definitely ask your rep or your consultants about a loaner set as well. Now, another big hurdle is thinking you don't have the patients for it. We always think scleral lenses are for patients with keratoconus or corneal ectasia, which is absolutely true, but it's also for a wide variety of other patients. I fit a lot of patients with ocular surface disease with scleral lenses, a lot of patients with just really high refractive error, presbyopic patients, patients with scars. So I really encourage you to try these lenses on all sorts of different patients. I'm not going to spend too much time on this next video, but the example is, we had a patient that had really bad blepharospasm, but also had a secondary dry eye diagnosis. And we saw that when we put the lens on the eye, it helped with her blepharospasm. So we started fitting patients with blepharospasm and scleral lenses to see if it would help. And we've had a lot of patients have some success with that. So, don't be scared to try these lenses on your patients. If anything, if you want to stick a lens on really quickly, see if it helps. Sometimes I'll do that just to see if it makes a difference in their vision or in their eye. And if it does, we'll bring them back for a fitting. But try it out. If you think it could provide some benefit either to the ocular surface, to the vision, try it out, see how it goes, and you can slowly start building up your patient base. Of course, if not within your own practice, talk to your fellow ODs, let them know that you're fitting these scleral lenses, that you have these fit sets, that you have these tools, and people will start to refer to you. Not everybody wants to take the time and effort to be on a webinar and learn these different things and get these tools, and you can be that resource for your colleagues within your area. Of course, ophthalmology is another great resource. They have a lot of these complex cases. They don't fit the scleral lenses. They want to refer to someone that does. So, if you have a corneal specialist or, any kind of ophthalmologist that you work with regularly, let them know that you do this. Even a retina specialist might have a patient that has keratoconus and they can send them to you. So let them know that you have these tools and you're available to help. Also, other medical specialties, rheumatology, they have a lot of patients with Sjogren's. They can be a great resource. So definitely reach out. Social media, we know, is the big thing now. So put it out there on your practice page that you do this type of lens, that you offer this new thing, and people will start to seek you out and find you. And of course, word of mouth is also a great tool.
All right, so are you worried about discussing the cost with your patients? This is one of my pet peeves. I don't like discussing fees at all, but you should not be apologetic about your fees. I mean, as you can tell, scleral lenses are, they're challenging. They're challenging to implement into your protocol when offering different types of lenses to patients, and they're challenging when it comes to fitting them. So there has to be a cost that is appropriate for that level of expertise that you've had to obtain in order to get to this point. So be upfront with the patient about the fitting process. This can save you and the patient a lot of stress in the long run. I tend to make sure that when patients are scheduling, when they're inquiring about scleral lenses, that my staff just gently discusses the fees. I don't ever want a patient to not come in to at least have a consultation based on fees. So I tell my staff that if they're, they balk at the fee, have them come in for a consultation, and I almost always can convert them into a scleral lens wearer. You may want to consider a specialty contact lens contract. This is something that I did not do for a very long time because I just didn't feel like it was compatible with the way that I wanted to practice, but I now feel that it is necessary. It doesn't have to be formal. It can just be something that you give the patient, or if you want to be formal, you can have them sign it, but it does need to talk about your fees so they know exactly what to expect. You need to decide if you want to do an all-inclusive fee or a per visit fee. I highly recommend an all-inclusive fee. You definitely want to talk about the warranty. Most manufacturers have a very generous warranty, and you have to determine whether or not you want to pass that on to your patient. Of course, you probably do, but that needs to be clearly delineated. You want to talk about the expectation for follow-up care. And then lastly, as good as we all may be at scleral fitting, you are going to have someone that's going to want a refund at some point. So you need to have that clearly defined in your contract, whether you have a refund policy. If you don't, then it needs to be clearly stated that there is no refund, but there needs to be a clear delineation of what the expectation if any, for a refund can be. And then lastly, sclerals may be covered by their vision plan, so you want to emphasize the may because there's only a few that actually cover it appropriately. So that just needs to be mentioned in the contract. This is definitely something that not everyone can have available to them, but if possible, it would be great if you had someone on your team that could be appointed as a billing guru. Things are constantly changing, fees are changing, reimbursement is changing, what's billable is changing. So to have someone that's on that pretty regularly would be super helpful. That may end up being you, and that's fine, but someone needs to be held accountable for how these claims are being submitted and making sure that you're getting reimbursed properly. You need to determine which codes are billable, because sometimes they're not, and some insurances require prior authorization. So that's a huge thing you want to know prior to fitting the patient. I think this is you, Dr. Hemmati.
Okay, so yeah, so another big thing is make sure you educate your staff. You know, as much as you're the one working the patient, your staff is also going to be having more one-on-one contact. So make sure your staff knows the right verbiage. As Dr. Tucker was saying, you know, maybe don't have them talk too much about the fees, have them know how much information not give and how to address or comment on certain things. You know, my staff, when I was working with them, they knew that if the patient had fogging or if they called with certain complaints, they all kind of knew what the first, you know, troubleshooting steps were before coming to me about it. So have staff meetings, educate your patients. And we also, and on the SLS website, there's a lot of great videos, both with application removal, going through the visits. So definitely watch those videos. I would encourage you to have your staff watch the videos as well, so you can kind of see what's going on with it. And that should also help. And same thing with application removal. Just like you should have a billing guru, I would recommend having, you know, someone from your staff be exclusively trained and be the person that's going to be teaching application and removal. It is definitely different than our soft lenses with application removal. There's a lot more variables as far as, you know, the age of the patient, holding their lid, their eyes not rolling up. There's a lot of challenges along the way with application and removal. So I would definitely select a staff member and have them be your scleral lens person. I also feel like application removal is the biggest hurdle for patients. And what always will frustrate me when I get a patient sent to me is someone who's tried this out. They weren't really trained very well. They maybe did it one time and they were sent on their way. This is a very overwhelming process for these patients. Getting this lens on and off every single day when they aren't confident, it's like starting your day out with something that's already feels like a failure. You know, you're not going to get the lens on, or it's not going to go on very well. So I'm pretty strict with my application removal. I make sure my patients, you know, do it in office at least 3 times confidently, or let them take it home, because I don't want them having issues once they have it at home and they're doing it by themselves. So I do recommend putting a little bit of extra time in this application removal process. Sometimes that does take a little bit more staff time or chair time, meaning you might have to bring them back for a couple training visits to get it there. In my experience, in the long run, that's led to much greater patient success. Another thing to always have is handouts. You know, as much as you go over everything in the room as far as solutions and steps of what to do, even which plungers to use, patients go home and everything goes blank. And, you know, if you don't have a handout already, once again, the SLS has some great handouts on their website. I actually use the essentials checklist with my patients all the time. We go through it. I check things off as we go. I let them know exactly which solutions they should get, exactly which plungers they're going to be using, and it's a great reference for them once they're at home. So definitely provide those handouts. And as far as solutions, they aren't always easy to find. So I'm very clear with my patients on where to purchase these, whether it's from Amazon or from the manufacturer or from, you know, wherever. I let them know. And I also have some supply at my office. We've all forgotten things. Patients will forget to order their solution, and then all of a sudden they're out of their saline and they don't know what to do. I will always have something available for sale. I don't sell in bulk. I still recommend that they purchase their bulk items online, but I will offer something in office as well so that they don't ever run out. They're never stranded. And I always remind them, don't go to the drugstore and just buy whatever. Likely those aren't the best options for you, unfortunately. And they just want to be very aware of what options do work for them. And then lastly, as far as tools, offer various options. You know, I use the insertion, the large plunger for inserting, the small plunger for removal, but all patients are different and different tools work better for different patients. Perfect example is this light inserter. You can see that some patients are going to prefer having that green light to focus on. Some people might prefer a blue plunger versus a white plunger. So I like to have options, show my patients different things, and see what works best for them. And then, you know, lastly, when you are seeing your patients, have a plan. That's going to make things go a lot more smoothly. I have a separate, you know, set of plans and agendas with my staff for initial visits, for dispensing visits, follow-up visits, and just those different steps, because some visits I want OCT, some visits I don't. So we have a very clear step-by-step rule of what we do with that patient when they come in on that day. Once again, another great resource, SLS has some examination forms, both for initial visits and follow-up visits. So download those, print them out. I use them as well, and it's a great sort of checklist, step-by-step of what you need to do. And another big thing is put aside adequate time. The last thing you want to do is be rushing and going really quickly, not doing the scans and taking the time to assess the way that you need to. I kind of typed out some things that I like to leave time for, like, your pre-lens measurements, putting the lens on, letting the lens settle. You can go see another patient while that lens is settling, but I usually let it sit for like 20 to 40 minutes and come back and take a look while I'm doing something else. And just, give it that full amount of time, just like with the application removal. If you have to do multiple visits, these patients are typically paying a premium. You are offering an inclusive service, and they are really reliant on you and these lenses. So for me personally, I think it's really good to put that time aside and to make sure it's a very thorough visit and they're getting everything that they need. And
all right, so we made it, Dr. Hemmati. So our last slide, and this is powerful, I think, for both of us, is you have to define success for yourself. There is so many different paths to the same endpoint. So a scleral lens can be considered successful if the lens is stable in the eye, the patient has achieved their best corrected acuity, the patient experiences comfortable lens wear for a reasonable amount of time, and then long-term wear of the lens does not result in any changes to the ocular surface. I think we both can agree that success it looks different for every patient. So don't put yourself in a box and set this super high expectation for every single patient, because that looks different. And just be happy in knowing that you've made a huge difference, and the work that you're doing is unmatched. You're doing something that's amazing for your patients.
Yeah, and especially when the ones that have different and different, but the ones that have different, surface abnormalities, different things going on. We talked about, surface non-wetting at the very beginning. I have patients that have GVHD that have been, a lot of pain, suffering with that just painful dryness for years, and lens is a huge game changer. Yes, they have fogging. Yes, they have front surface dryness, but they don't mind managing around that, taking the lens off, wiping the surface of the lens, because they still feel like they have their life back by having that lens. So
yeah, so we didn't list number 5, no fogging, because we know that's probably unrealistic.
Yeah, so no, just keep in mind that there's different goals with every different patient, and be realistic with your patients on what we can and can't achieve, and see how they go through the process. And like you said, have fun and just see how it goes. You gotta just try and then go from there.